Good afternoon, everybody. I hope you had enough time to have a little bit of lunch. And it's my pleasure to introduce this session, Align for the Future, with case-based discussion on next-generation balloon expandable transcatheter heart valve technology. This is a session sponsored by Myval. And the session objective is to experience the versatility of this platform in challenging scenarios by sharing some cases, to learn about lifetime management in TAVI using the novel Commissural alignment technique called OctaAlign, and to learn about the novel Myval Octacor THV. So, as you can see, we have a panel which is pretty large. My co-chair spokesperson is Niels van Rooyen. I'm here with Oscar Angers, with Christian Engelsberg, with Axel Link and Francesco Saia. And without further delay, I would give the voice to Eric Nissen to tell us about the first, the landmark RCT, and there will be some time for discussion, hopefully.
Okay, thank you very much. So this is a rather promising title, but I have 8 minutes, so it'll be related to the force of a lot of the technical stuff mostly. So these are my conflicts. So actually, the first Myval was implanted in 2017, and just a little year later, the first 30 patients were presented in a publication, and since then, there's been more than 15,000 implants worldwide, and the company is expecting to double that within a year. So it's not exactly a completely new valve regarding implantations, but to a lot of TAVI operators, it's still a new valve. So I'll be given a chance to give a tour de force within the next 8 minutes of the technical details of this valve. It's been used, of course, in all the IFU cases, but also, as you see below, in all these off-label cases where we are forced to use TAVI valves occasionally. It's called Octacor due to this octagonal design with two identical rows at the upper row and in the outflow zone and lower in the inflow zone, with overlapping parts which give this rhombus body and supports the valve in the longitudinal force. It is quite unique in that it is, due to this design with identical cells, it expands completely in a controlled fashion, identically from top to bottom, and only for shortening 19 to 20%, which gives quite good confidence when you're implanting the valve. It has an open cell structure, which gives ample access to coronaries. Its lower half is with closed cells, of course, due to the PVL, to mitigate the PVL, and then it has an external shirt, which sort of both mitigates the PVL and also sort of saves if hostile calcium or other stuff could impede the valve function. It's a cobalt alloy frame with a good radial strength, and it has a proprietary anti-calcium treatment from the company. And this external skirt allows good accommodation to calcification annuli. It has the largest range of valve sizes, both within the presently covered valves, but also it has these extended 30.5 and 32 valves. So it gives good room for hostile anatomy, where as of yet we have used a balloon expandable valve. We had to sort of occasionally make some adjustment, put a little more or a little less volume into the valve, and that is probably not without a problem, but we really don't know, because we are sort of moving away from the intended size, which the designers of the valves had planned to be the correct size, and then we're using these intermediate. It might not have an impact, but at least with this valve, you can have these intermediate sizes without having to worry about that. They also seem to have found a niche, since these intermediate sizes are used in, as you see here, around 40% of the patients. And as a personal comment, it's quite nice that if you have my stature, there's now also valves which can be used, especially in the Nordic and Northern Europe, where we have large people. And they go now to these 30.5 or 32 valves, and you see in the Netherlands actually 12% have been implanted one of the large valves. So that's quite nice. The implant system is quite flexible. It can be flexed when you cross the arch, and I do it. It's really not necessary. It follows very nicely along the arch without flexing. But it also gives advantage if you have to go to tortuous anatomies, as we encounter once in a while, very kinked aortic portions which you have to push a lot. You don't like to do that, but you can easily navigate through that. Another advantage is that you see you have to put quite large volumes into that. So the days where you implant the large valves, you don't need to go to the gym, because putting in these 32 milliliters really is forceful, because presently you have a very large footprint on the available inflators. And you really have to focus that you get all the way down, because you feel so much resistance all the way. This is going to be an immediate problem, because there should be a new inflator on the way with a normal small footprint, so it's more like the standard pressure you need. Okay. They have their own proprietary sheet, which is expandable. Same sheet used for all sizes. It comes with a loader for 2 different loaders depending on the valve size, but it's the same valve that goes into the same sheets, regardless if you start with the 20 or you end with the 32, and it works quite nice. For the larger valves, it's recommended that we do a pre-dilatation with an 18 French dilator before you introduce the valve. The valve is loaded outside the body directly on the balloon, so that once you get into the sheet, it's a direct route to the aortic annulus and implantation. You don't have to do that usual intermediate step that you have. We have markers extending where I think this one, where you want to put them with the landing zone. They're going to slide a little later on that. And then they've got these shoulders, which sort of keeps the valve situated where it's supposed to be, also if you have a lot of force when you pull it through the groin. Another advantage, or a very important advantage, is that it is retrievable. So occasionally, when you put on balloon expandable valves, even though it's a 14 French system or a 16 French system, you have to take account when the valve comes in, it's quite a bit larger. So you occasionally need to prepare the vessel. And in this case, you don't have to be so forceful when you start preparing the vessel, because you have a bailout, you can take it out and do some more prepping on the vessel, which is a quite nice feature. Once the valve is in the position, you can see I put in a yellow line here. You have to negotiate so that this marker, the marker, the black dot, sits just above the annular plane. And then when you inflate the valve, it's quite nice that it's inflated in a dog bone version, since it has 2 ways of leaving out the contrast. And that gives also a very good stabilization while you inflate the valve. And it's quite easy to inflate and take out and in. It goes quickly. And this looks like something you've seen before, but it has some additional features. You see on the right there is a small clock on the crimper, and that is needed for that patient-specific valve loading that we'll hear more about. But that's a commissural alignment. You can really align the valve for the individual patient. And I won't go into many of the details, just to show you, because it's a little tricky, so you hear 2 times. But in essence, you find out where the right coronary departs, and that uses you for where to crimp the valve. So in this case, for example, the right coronary goes at 12 o'clock. Then what you do is that you put in the valve with one of the posts directly at the right coronary departure, in this case 12 o'clock. And then what happens is that when you put in the patient, what is superior in the crimper becomes anterior in the groin, and as it moves along, it becomes posterior in the patient. And that's you have to move that around your head a few times. But in essence, what it does is that what you just see this little bit, it sort of puts the valve in the correct position compared to the coronaries. So this way you can sort of make sure you try to avoid compromising the coronary access. So a lot of technical features which seems interesting and relevant, but just yesterday we heard the landmark trial, which I had not time to go into details, but you heard it and you can see it afterwards. But in essence, it just showed that it seems to be at least not inferior to the present market leaders. And it did give quite good results. And also we're looking at the hemodynamics. It seems as if it made at least as large valves and as low gradients as the current valves on the market. So pending what we always look at, what about the long term? We do not know. We will, in Denmark, we've made a randomized study which will be published sometime later this year, where we randomized a little over 1,000 patients to Sapien or Myval, so we'll get some additional data, 1-year data here later in this year. Until then, it's probably up to the community of how to adopt this technique. It seems to allow us to treat a lot of anatomies that we couldn't previously and doing it with the intended inflation volumes, and still also maintaining optimal coronary alignment. And now we have these randomized data, so we will see how this will be adopted, because it's always the schisma. We don't have long-term data. When do we dare to sort of use all these very nice data features we have now to say, okay, we go along, or should we wait for the Danish 1-year trial, or maybe longer? Thank you very much.
So I think it would be nice to have a short discussion after each presentation. I remind all the audience to be part of the discussion. You know, it's an opportunity to share opinions and ask questions about a new technology. So who wants to comment on this?
Yeah, a very nice presentation. So you also nicely showed that this commissural alignment is easily done. I mean, how often do you use it, or do you use it as on a regular basis?
I mean, it's very easy. We always do the commissural alignment or the coronary alignment. If there's a very strange offtake of the coronaries, then we of course prioritize the coronary alignment. But we always do it. It takes 15 seconds to get that idea when you do the CT analysis.
Well, especially when we come to younger patients, this seems to be of interest.
Younger patient, and if you're considering doing a valve and valve, at a point it doesn't make any sense if you put a post outside the coronary. So that's a lot of good ideas to do that.
So, please go ahead.
Yes, that's a nice presentation, and with your huge experience from the TAVI Compare trial, comparing Edwards and Myval, what would you say in the startup of Myval? What's the main difference in deploying the valve compared to Edwards?
It's really hard to find. There's these few technical details. You know, the markers look a little different. You have but basically everything in the procedure. I mean, you need 1 day of proctoring, then you go along.
Because I mean, this foreshortening, it's quite a big difference, I think, when implanting. You have to really be aware that it doesn't foreshorten as much as an Edwards valve. And you have to take that into consideration.
Yeah, but when you use that are two, I didn't show that, but you can either use the marker, if it has slipped a little bit on the balloon, which occasionally happens, then there are some stuff on the valve you can see, and it's like losing white line in the Sapien. It's very easy.
The technical question, maybe somebody is less used to this device, is that you have a broader range of sizes. So you have the intermediate size. It looks like confusion maybe is an advantage. So can you share your opinion about having more sizes?
Yeah, so just try to say we do not know if it's. I mean, it's nice because when we have the Sapien valve, there are not rarely patients who have a large chunk of calcium or something other that you would not like to force the system, and then you have to take some compromise, taking either volume out of the number larger or putting additional in the number smaller, and we've done it all, and it works. So it's not. I mean, theoretically, it's a good idea. It takes a lot of stock place. But,
and before I give the voice to her, so then the next is, where do you think there is a largest advantage? Because, durability, because you just mentioned durability, patient prosthesis mismatch, AV block, and what you think is the advantage having more sizes? The best advantage? Guess. It's just a guess. Obviously.
Yeah, I mean, just taking off the mental load of forcing a Sapien in a position or a size where you would rather not do.
Okay, thanks. There is a question from. Yeah, you hear.
Hey, just a quick question. You're talking about the Octacor system treating most anatomies, but then you're talking about the landmark trial. How much Octacor did you have in the landmark trial? I'm just a bit confused whether there's an amalgam here.
Yeah. To be honest, I don't know. I'm not part of the landmark trial, so I don't know the fraction. how many are the original first generation Myval, how many are Octacor, I don't know if the company.
Well, I can answer that. So that is indeed relatively low, but I think in the compare, the majority is Octacor, right?
Yeah, I think we'll end up something like 50-50 because we had this legal issue with standstill, and then we switched to Octacor in the latter part. Yeah.
We will keep discussing. I mean, stay in the room because there will be more time at the end of the presentations, and we will move forward now. The next presentation is going to be actually about the commissural alignment technique, the so-called OctaAlign, from Jean-José Erungaren.
Thank you very much. So I'm quite happy to be here to talk on the OctaAlign technique of commissural alignment with the Octacor device. These are my disclosures. So usually we associate commissural alignment with self-expanding valves, but there can be some advantages for the balloon expandable platform as well. Commissural alignment has shown to improve hemodynamics and reduce leaflet stress. Studies have shown increased risk of high gradients and subclinical thrombosis with commissural misalignment. And as TAVI moves to younger population and low-risk subjects, there's an increasing need to preserve access to the coronaries for future redo procedures. Commissural misalignment can make leaflet modification strategies difficult, especially in the context of valve-in-valve or TAVR-in-TAVR procedures. So what is OctaAlign technique? It's a simple, easy-to-use technique for commissural alignment using the Octacor device, but I think this strategy can be used for any balloon expandable platform. So basis of the OctaAlign technique is that in a native tricuspid aortic valve anatomy, the three commissures are separated at 120 degrees angles to each other, and this goes to 180 degrees in a type 0 bicuspid anatomy. And even the commissures of the Octacor device are also separated at 120 degrees. Ideally, the right coronary artery originates from the mid of the right coronary cusp, and the left coronary artery originates from the middle of the left coronary cusp. However, there can be minor variations in this anatomical position. So in order to achieve commissural alignment, we propose that one of the three commissure posts of the Octacor device should be aligned with the mid-sinus of the right coronary cusp as obtained from the CT image. And once the valve is crimped and delivery system is advanced within the aorta and the arch, the anatomy of the valve changes, the orientation changes to from the anteroposterior to posterior anterior, resulting in minimal commissural misalignment. So here are the examples of some patients. First patient is a patient with a tricuspid aortic valve anatomy. As you can see in the CT, this patient has got a tricuspid aortic valve, minimum calcification, annulus dimension is 22.9. And this is how we do the commissural alignment with the OctaAlign technique. On a commercial software like 3Mensure, we capture the transverse cross-sectional image of the mid-sinus of valve salva, and then we draw a horizontal and a vertical line intersecting the middle of this cross-sectional image. This intersection of these lines, we label it as the geometric nodule of the sinus. And then we draw a line from the middle of the right coronary cusp to the geometric nodule of the sinus. And the angle that's formed is called the angle of the commissural alignment. And once we superimpose half clock over the face of this image, we get a clock angle, and angle of commissural alignment corresponds to the clock angle. So in this patient, the clock angle was 3 o'clock, which means the middle of the right coronary cusp was in a 3 o'clock position. And this is how we'll crimp one of the commissures of the Octacor valve, as you can see here in the picture. And here is a short demonstration of how we crimp the valve. And once the valve is crimped, we have to make sure that the mirror logo on the delivery system is kept upward facing as you introduce the delivery system through the vasculature into the aortic annulus. So crimping one of the commissures in the video at 2 o'clock position, and then you take the delivery system with the mirror logo facing up. So once that is done, we take the Octacor valve. This case, we used a 24.5 mm device. You can clearly see the landing zone marker prominently at the level of the base of the pigtail in the non-coronary sinus. And you can also appreciate the Octacor device as a quite stable and predictable deployment. Valve foreshortened quite less, and final result is quite good. There's no leak, no significant gradient. At follow-up, we did actually CT, and you find that this patient has had a perfect alignment with the native commissures. So in case of bicuspid valve, we have to actually use a coronary alignment in which the clock angle is derived from the angle formed between the horizontal line and line connecting the right coronary artery, as you can see here in the picture. So here are some examples of bicuspid aortic anatomy. On the left is the type 1A bicuspid aortic valve anatomy. This patient has a clock angle of slightly less than 3 o'clock position. But sometimes in bicuspid anatomies, we find the coronaries actually arise opposite to each other. In those cases, we cannot use coronary alignment. We actually have to go for a commissural alignment. And here the commissural alignment angle is about 3.5 as opposed to a coronary alignment angle, which would have been something like a 2.55 or so. So the results of the OctaAlign techniques in a small population of 30 patients was published last year. So what we find is that 2/3 of tricuspid anatomy and 3/4 of bicuspid aortic valve anatomies, we found at least a good amount of commissural alignment. However, this is a very small study, and results need to be validated in larger trials. So in summary, studies have shown that commissural alignments do have a role in balloon expandable TAVI. Currently, there's no standardized technique for commissural alignment with balloon expandable valve. OctaAlign technique is quite easy to use and reproduce, but we don't know in tortuous anatomies and tortuous aortic takeoffs what would be whether they will affect the technique. With this, I end my presentation. Thank you all.
Thank you very much. Any comment? I can start just saying brilliant solution, very simple solution. Put the clock on the crimper and make it a complex decision making simple. Thank you. So,
I have a comment just in terms that we know that most of the balloon expandable valves have a short frame, so actually all of them have short frame. Most of them sits behind coronary, so the coronary orientation is not really a major issue. I mean, let's say in general, it's 10% of the cases in which you may have a supracoronary position, but I still think this is something that is very important to highlight, is something that is very important to achieve also with these valves, especially when we think about lifetime management, because again, they may be 10% of the patient, probably with the technique that we adopted at a later stage, not to implant higher to reduce pacemaker, maybe even more, maybe 20% of the patient. So I think this is really a good direction to go. It's very important that all the technology will try to achieve coronary alignment. And as you highlighted in your last slide, I mean, for sure, for every kind of device, we have problems with self-expanding valves. We know how to do it, but still when you have tortuosity and so on. So I think that's a message that I think all the company have to work more on this.
yeah, and even if in a balloon expandable the issue is a bit less than in self-expanding longer profile devices, still if you think about lifelong management, once you do a TAV in TAV, the leaflet will reach the level of the upper margin of the frame, and therefore if you have a challenging anatomy, you can't do leaflet management if you have the commissure in front of the coronary. So it's all. I mean, we are 20 years after the first cases, so now we need to really think about perfection, and commissural alignment, or better, coronary alignment is, I think, a key element.
Yeah,
so who has do not care too much? I mean, is there anyone in the panel that thinks it's not that important for balloon? Axel, you do a lot of cases. Come on, I can, because this now we are becoming a bit sophisticated, and obviously,
I totally agree. I think coronary alignment is a must nowadays, and especially since we are treating low risk young patients, and if they would have undergone surgery, they would have a optimal result, and I think it's a goal to achieve the same with TAVR. I think the smaller the anatomy, the more important is coronary alignment, not only with regard to valve degeneration, but also with regard to coronary perfusion. And I think if you have a commissural post just in front of the coronary and the patient starts to exercise, we don't know what it means to coronary perfusion pressures and shear stress in the coronaries and coronary health over the long term. So I think this is an important aspect. And as I said, the smaller the anatomy, the smaller the sinus, the less forgiving is the situation for valve implantation. So you should take whatever is necessary to have an alignment. I think what you mentioned is very important. The longer the arch, the more tortuosity you have on the groin and on the aortic arch and the ascending aorta, the more unknown factors lead to a rotation of the valve. And I think, therefore, for the future, it's essential to have additional markers on the frame to check of what has been, tried to achieve by crimping the frame in a certain position is maintained while you reach the level of the annulus. But as far as I know, the engineers have already thought about this, and the next generation of the valve are going to have markers on that too.
And obviously, then you need more torqueability on the delivery system. Otherwise, you can't control rotation once you are in the annulus. Okay, great presentation. Thank you. Very simple, very straightforward, like the solution that you proposed. And then we go. The next presentation is going to be given by Ingo Eitel about the procedural and clinical relevance of these intermediate sizes in TAVI.
Thank you, dear panel, dear ladies and gentlemen. It's a great pleasure to be part of this session. So my disclosures. So the TAVR evolution in the last 20 years is truly remarkable, and it really transformed the treatment of patients with aortic stenosis. And most importantly, what we saw already in the first talk, we have a rapid technology evolution also of the TAVR prosthesis. The latest Octacor has been nicely shown. We have a simplification of the procedure. We have a dramatic reduction in complications and improved outcomes. And most importantly, we have a very, very robust body of evidence. We clearly saw in large multi-center trials that TAVR is at least non-inferior or even superior as compared to surgical aortic valve replacement in high-risk patients, intermediate patients, and now we also have the data for low-risk patients. And the latest piece of evidence was just published in the low-risk patients some weeks ago in the New England Journal and presented at the American College of Cardiology meeting. And this trial also has unique characteristics because it reflects a little bit more the real-world setting in which operators have unrestricted access to the temporary TAVR devices. And the valve selection by the local heart team on the basis of the individual patient anatomical and medical considerations is very, very important also for the outcome, so that you choose the most appropriate and suitable device for the individual anatomy. And this was always a little bit a problem of the industry-sponsored trials in the past, because specific TAVR devices were tested in selected patients. And in this low-risk TAVR trial, there was a really consistent and convincing reduction of stroke and death from any cause, about 47% for the TAVI population against to the surgical replacement, and death from any cause was even reduced by 57%. So we now really have the evidence to go to the low-risk cohorts, to the low-risk patients, and all people coming to our hospitals For example, to Professor Linke, to Dresden, to Professor Maisano, to me in Lübeck, everybody wants to have a TAVI, independent of risk and age. And so we really have to ensure to have a perfect, optimal implementation because we want to reduce complications, we want to ensure optimal durability, and therefore we need to perform a precision TAVR implantation, and we have to tailor our choice of the TAVR device to the patient. So no compromise, not undersize, not oversize, not a little bit more fluid in the balloon. No, we want just the perfect size for the patients. According to the prosthesis to patient concept, we want to preserve the prosthesis valve geometry and respect the patient's anatomy. So we still face some challenges, even in 2024, and even with the improved prosthesis. So durability is a big topic, and this is also correlated with optimal size. So we want to have an optimal size, optimal expansion of the prosthesis. So coronary access is also a big issue. It's not a main problem for the balloon expanding valves, but we already talked about alignment, how important it is, and it can nicely and easily perform with the Myval Octacor. But for sure, we want to avoid pacemaker implantation, so we want a high implantation, and we want to reduce PVL, and because we know that has a negative impact on outcome, and this has also to do with optimal sizing and optimal expansion of the valve. And we already heard in the panel discussion, prosthesis-patient mismatch is also an issue in TAVI. So we know this as a well-known phenomenon for our surgical colleagues. In about 1/3 of patients, we have a prosthesis-patient mismatch, but this is also true for TAVR. So in clinical trials, 10% of patients have been identified with a severe prosthesis-patient mismatch, and this clearly has also problems then probably with long-term durability of the prosthesis. And as TAVI implanters, we have a lot of choices. So, and we have to consider the optimal device selection for the patients according to clinical factors and also according to anatomic features, for example, annulus size, but also how is the calcification, is the aorta horizontal, and then we have to select the appropriate device. And the sizing, in my opinion, is really, really a key issue. And you see the different TAVR manufacturers, and now we have the option with the Myval Octacor. We have 9 sizes starting from 20 up to 32, and there we don't have to do any more compromise like under or oversizing or put more fluid in the balloons. Now we can really choose the optimal size for the individual anatomy, and this wider range is really allows a precise matching of the implanted valve, and we have just 1.5 increments as compared to 4 sizes, for example, for the Edward Sapien with 3 millimeter increments, so you have a really fine calibration. So here's the chart for the sizing. You see you can nicely treat small annuli, but you can also go up to annuli up to 800 square millimeter. We will have another talk about this topic afterwards. So, and is this clinical relevant? So is it nice to have or is it really used? Yes, it is really used. So in approximately half of patients, we have data, and this is also true for our hospital, that according to the CT annulus sizing, that intermediate size of the Myval Octacor is selected. And we already talked about the really, really promising landmark randomized controlled trial. And in the landmark trial, half of patients also were implanted with the intermediate size with the Myval or the Myval Octacor device. So here are 3 examples from our hospital. 3 patients treated with intermediate sizes, 30.5, 24.5, and 27.5. You see no regurg at all, optimal sizing, optimal positioning. So great results of our patients. So does size matter? In my opinion, yes. We definitely need to regurge PVL, so reduce PVL. We have to reduce pacemaker implantations, and we can ensure this with the optimal sizing. And so life-threatening complications are rare, but it still happens. So also valve embolization, annular rupture can be reduced. And if we talk about pacemaker, we also have some data that the Myval has, or the Octacor has similar pacemaker rates like the Sapien and the Accurate, but the pacemaker rates for the self-expanding valves in this observation study, for example, for the Evolute, were significantly higher. And also in the landmark trial, I looked up the data, so there were numerically 2% less pacemaker implantation. This was not significant, but numerically it was less pacemaker implantations in the Myval and Myval Octacor group as compared to the other contemporary devices. So in conclusion, so we need the optimal TAVR device selection and sizing. This is essential to ensure an optimal TAVR result. We should definitely avoid under and oversizing, no compromise. The broader size matrix we saw in all talks of this session really ensures the optimal sizing according to the anatomy and the annulus parameters of the patient. We demonstrated in the landmark trial and also in other registries and in clinical routine that is very helpful. It is used in almost half of the patients. And in my opinion, because this was already discussed by the panel, so if we have the optimal size, we really have good chances to also have better outcomes and reduce complications. And I haven't talked about the XL size. This will be the talk after me, but this is also an unmet clinical need, and we definitely need to have the option to also treat this large annuli, because this potentially also allows to expand the TAVR indication, for example, for aortic regurgitation, also in bicuspid anatomies, but for sure we need more data in these indications. Thank you.
So Ingo, let me just start a bit of discussion with you about having the intermediate sizes. What I don't like is all this the debate. 1 cc more, 1 cc less. I hate that. I think having the full spectrum, yeah, because there is no science there. I mean, really, there is a lot of, and also, but you didn't mention one potential drawback of underfilling the syringe in a balloon expandable valve, which is patient prosthesis mismatch. I mean, if you don't expand the stent completely, you might have issues in the opening, as well as if you overexpand, also the opening capability of the leaflets is somehow diminished. So do you believe there is an advantage also in terms of hemodynamic performance, acute hemodynamic performance, in terms of less frequent patient prosthesis mismatch and less frequent intravalvular leaks?
So very important point, and actually we saw that in the landmark trial, because we have data from landmark that the effective orifice area is, in comparison to the Sapien Edwards device, is superior. So it was similar to the supraannular device, but it was better than the Edwards Sapien. So in my opinion, that's also very important, probably also for long-term durability. And in my opinion, that's very promising data. But, so we already heard it in the first talk, we definitely need to follow up the patient and see if this really translates in clinical outcomes.
Can I ask you one question? Why do you think Edwards is not also producing the intermediate sizes now? Maybe there is
so
Edwards in the room. Maybe somebody wants to answer.
Is somebody of the company here, so probably they can answer. So actually I don't know, because in my opinion there's definitely the clinical need, and it helps to achieve better results. Probably after the landmark results, they will move a little bit and probably also think about if 4 sizes is enough, or probably to go a little bit up.
Actually, it's even before the landmark trial because, I mean, the X4 generation of Sapien will allow for every size to have 3 different inflation of the syringe, but this should be designed not in order to have an approximation, but should be very precise, and the valve will be designed in order to be perfect for the 3. I mean, the 3 sizes for each one. So I think this highlights that the direction is correct. I mean, that also everything that you said about the importance of having a tailored valve precisely. I do a lot of balloon expandable valve. I do a lot of 1cc more, 1cc less, 2 more, 2 less. But I think, again, this is very relevant for the procedural results, but we don't know how much this impact, even if we can say that small adjustment probably do not impact on durability. And we should be very cautious when we translate automatically gradients into durability, into clinical outcomes. But still, again, in a world in which we are treating younger, lower risk patients, looking at perfect result, longer durability. So I think that being very precise and accurate in every aspect is more and more important.
Can I just take the advantage of having cardiac surgeon next to me and ask how many sizes do you have for surgical valves? And are you performing in all of the patients as CT before surgery? Yeah, and then choosing the just perfect valve for this patient?
I think from a cardiac surgery perspective, first of all, you can implant a smaller size than the annulus valve without any, or with limited damage. The only thing is that probably is a bit higher risk of PV leak, and obviously you have worse hemodynamics. So you size the valve after you remove the leaflet. So it's a bit different approach. Also, sizing with CT scan, somebody is doing that, but again, technically speaking, it doesn't make much sense because then you can size the remaining tissue which is available there and do a different approach. What is for sure clear to me is that many surgeons are a bit scared of implanting the snug to fit size. They implant, at least in the past, they were implanting 2 small valves, and that's the reason why surgical valves are behaving worse than TAVI. I think if you are a good surgeon, a good valve works very well. So in the younger population, although there are now some data which are now challenging surgical AVR, I still believe that surgery can play a role.
But don't you affect the height of the coronaries if you implant a too low valve in surgery? And then I mean for valve-in-valve procedures later it will be difficult because of the height.
Even in surgery you can implant the valve intraannular, supraannular. It can affect actually the next step, and that's why in surgical meetings we start hearing concepts like a Bental procedure whenever you have a small root. This is already coming, which obviously increases dramatically the risk of surgery. So I don't know where we are going, in which directions we are going, but again, now I put my cap as a surgeon. I've been always a believer of TAVI, so I have a little bit of bias. But as a surgeon, I have to say that TAVI has been also a driver for improving outcomes in surgery. The surgeons know that the bar is much higher now. Thank you for making me reminding my profession. Yes, and I think I'm one of the few here at the Euro. Listen, Alfonso Ielasi is now talking about the last and very important feature of this device, which is the XL size and managing extra large annuli. So, Alfonso.
So, good morning, everyone. Thanks, Francesco. In the next minutes, I will talk about the management of extra large annuli. My disclosures. So, TAVR procedures are growing worldwide with a high number performed every day in every cath lab in the world. And as operators, we are facing with more and more complex anatomies. And one of that is the XL annulus. The main challenge when facing with this kind of lesion subset is related to the lack of THVs with proper size, because with balloon expandable devices, the maximum area which can be covered is 600 millimeters square, while with the self-expanding valves, it is 95 millimeter in terms of perimeter. So, looking at this data coming from a multi-center analysis on more than 2,000 consecutive patients underwent TAVR screening between 2012 and 2020, a not low number of patients had an extra large annuli, as you can see from the image, and the most important reason for anatomical contraindication for TAVR was related to the extra large anatomy. So the Myval family is the only one providing us extra large sized devices, in particularly the 30.5 mm and the 32 mm devices, covering up to 840 millimeter square areas, and even more, adding some cc extras. So focusing on Myval Octacor, the new iteration of the Myval family, as you can see, the design is different as compared to the first generation Myval. So 2 rows of hybrid interlacing octagonal cell geometry with a higher internal external cuff and internal skirt. The design is associated with a nice behavior in terms of foreshortening, which is lower as compared to other balloon expandable devices and self-expanding devices. So as you can see from this image, the positioning, the foreshortening, and the final deployment of the device is very stable and precise due to its design, even for XL sizes. So moving from theory to clinical cases, I would like to share with you some interesting procedures performed in patients with extra large annuli. So patient number 1 is a 78-year-old male with severe aortic valve stenosis plus moderate aortic regurg. LVEF was 45%. At CT evaluation, the area at the level of the annulus was 719 millimeters square, while the LVOT was smaller. Sizes at the level of the STJ ascending aorta were fine, while the aortic valve was a bicuspid one, RAFE type 1 and 2R RAFE. Coronary height was okay, and also the peripheral axes were relatively huge, so able to be crossed with our device. In particular, looking at the size matrix chart, according to the 3D annular area of 719 millimeters square, it was decided to implant a 32 mm Myval Octacor with an oversize of around 12% at the nominal volume. So the plan was to deploy a 32 mm less 2 ml empirically. The deployment was planned to be direct, relatively high in terms of implantation depth, under rapid pacing and with cerebral embolic protection. So this is the basal aortogram. Then the valve was checked once still into the sheath in order to verify the correct position between the two stoppers. Then the 32 mm device was advanced with some difficulties at the level of the arch, which was very angulated. The wire into the LV was Safari, small wire. And this is the deployment with the bottom of the RadioPEC marker at the level of the bottom of the pictal. The deployment was very stable, and the final result was fine, I would say, with a trivial PVL, no conduction disturbances for these patients, no other complications. He was discharged 2 days after the procedure. Case number 2, 84-year-old male. He underwent prior surgical aortic valve replacement with the implantation of a stentless Freedom Solo 27 mm valve. He was admitted to our unit because of pulmonary edema. LVEF was 30%. The patient had severe pulmonary hypertension. And at echocardiography, as you can see, a massive aortic regurg was diagnosed. There was the dysfunction of one of the 3 leaflets of this surgical bioprosthesis. In particular, this bioprosthesis has an internal, true internal diameter which is almost the same to the external one. And based on the CT analysis, the annulus area was 714 millimeters square, while the LVOT was around 1,000 millimeters square. No calcium, as you can see, at the level of the degenerated leaflets, and the takeoff of the left coronary artery was around 6 to 7 millimeter. So we are facing with an extra large annulus with a very extra large LVOT, which is dominant, no calcium on the leaflets. So this was a pretty complex case because the anchoring for our balloon expandable valve was not probably the best, but for this patient we had no other options. So looking at the size matrix chart, implanting a 32, deciding for a 32 mm Myval Octacor, the oversize at the nominal pressure would have been of around 13%. So we added 3 cc empirically, even in this case, into the balloon, and a direct high and slow deployment was planned under rapid pacing at 200 beats per minute. Coronary protection on the left was positioned. So this is the baseline aortogram, the transit of the Myval 32 mm through the aortic arch using the navigator delivery system. Then the positioning and deployment. So the bottom of the RadioPEC marker again aligned to the bottom of the pictal. So the deployment was very slow and homogeneous. Expansion of the valve was detected at the end of the deployment, as you can see. And this is the final result. There is still some leakage, but in terms of hemodynamics, the patient, the result was fine, and I would say acceptable if we consider the challenging anatomy we were facing at baseline. Even a coronary stent was implanted from the left main to the upper segment of the aortic edge of the Myval Octacor in a mini chimney fashion, just to favor the left coronary artery patency. And this is the CT scan performed a follow-up showing the eye implantation of the Myval Octacor into the Freedom Solo degenerated. Case number 3, an off-label case, 68-year-old male with a severe collagenopathy, LVF 45 to 50%, severe chronic kidney disease, refused for surgery. He had a severe aortic regurg, but was referred for evaluation for TAVI procedure. The area was 713 millimeters square at the level of the annulus. LVOT was smaller, and this is a favorable feature for the treatment of pure aortic regurg. As you can see, the leaflets are without calcium, so no calcification, and more the peripheral root was extremely tortuous at the level of the abdominal aorta and even thoracic aorta and aortic arch. So based on the CT area assessment, the Myval Octacor 32 was chosen, and at nominal volume, the oversize would have been of around 13%. In this kind of cases, it is very, very important to oversize the device as much as possible in order to favor the anchoring. So even in this case, we added 3 ml of extra solution, again empirically. The deployment, of course, was planned to be direct, high, and slow under rapid pacing. So this is the baseline aortogram in 2 views. So as you can see, the regurg was really massive, and even from this aortogram we can appreciate that the LVOT it is at least tubular as compared to the virtual basal ring. Tortuosity was extreme, as you can appreciate from the fluoroscopic views, but the navigator was advanced not easily, but it was advanced. At the end, we were able, even using the Safari small wire, no Landerquist, because this patient had very, very soft and fragile vessel. He had some injuries, again, in the past performing interventional procedures. This is the deployment, so the valve was sucked down into the LVOT. As you can see, after the first deployment, and the valve was not very stable, but it was trying to find its anchoring at the level of the LVOT, which was smaller as compared to the annulus. So we post-dilated, adding 6 cc extra, and the final result is pretty satisfying if we consider the baseline and the no option. So in terms of data, we have not so many data on the performance of XL-sized Myval. We have data coming from short experiences in both aortic stenosis and aortic regurg, but even if the sample were relatively small, the device success is relatively high in all the population. Permanent pacemaker rate was high in two cohorts, but I think it is reasonable because, yeah, we are implanting very large devices, so the stretch of the tissues can be really a lot. No significant major vascular complication, and no major moderate to severe PVL. I mean, the higher rate was 8.9%. So in conclusions, XL annual sizes represents a challenging scenario for TAVR. Myval THV series allows the treatment of all patients with aortic stenosis and many patients with aortic regurg and extra large annuli. Octacor's 2-row design is associated with less foreshortening and precise THV deployment even in extra large annuli. Balloon overfilling may help to tackle even XXL annular sizes. Thank you for your attention.
Thank you, Alfonso. We have 3 minutes left, space for one question. If anyone has a question, I mean, you already showed the best indication for the XL, very interesting indication with AI, pure AI. Is there any questions? So if there are no questions, I think I will hand over to my so-called spokesperson, let's say co-chair, is always a debate. Spokesperson is the one that should speak. You didn't speak, so is the time to speak and lesson evaluate what we learned.
Yeah, so a spokesperson is actually speaking on behalf, right? So you can use me to send out your message. No, I think we had a great session today. We learned a lot about this new valve. We have learned about the technique of coronary alignment. We all have the feeling that it is important. Well, the future, of course, will tell, but it is easily done, and it is something that I think we should incorporate in our cases, and then see in the future whether this all actually has a benefit. I think a little bit the same is true for all the intermediate sizes. So for us, it's of course very nice, just like with coronary stents, that you have these exact sized valves for your patients. So also their future will tell us whether it will actually lead to reduced paravalvular leak cuts, reduced pacemaker implantations. We've learned about the extra large sizes. I think there this platform fills in immediately an unmet need because there is no alternative on the market. And finally, I think that's I think the most important take-home message. We now see all these different valves and techniques evolving. We come from an era where we had two platforms that proved to be at least equivalent to surgical techniques. Now we're getting into a new era, just like for PCIs, where we need these head-to-head trials. And I think in that respect, Landmark is the first successful head-to-head trial in TAVI. It is only 30 days, so we will have to await 1 year results there. But it's something also that we should consider if we make these choices for patients. We should not only base that choice on a CE mark, but rather base it on evidence-based medicine that we get from these kind of trials. So I would like to thank all the speakers, and I would like to thank the audience, and well, enjoy the rest of PCR. Thank you very much.